Hello, everybody. I really thank you, the organizing committee, for inviting me at this prestigious conference of North Macedonian Anesthesiology Congress. My topic for today is complication related to COVID-19. I am Professor Rudin Domi, professor of anesthesiology and intensive care, University of Medicine in Tirana, Albania. As everybody knows, complications after COVID-19 are multidimensional, are respiratory distress, infection, pneumonia, or neurological complications or cardiovascular complications. Of course, we faced pancreatic injury and acute kidney injury, septic complications, still septic shock, cytokine storm, and acute liver injury. So it's not a disease only focused on lung, but can be spread in all the organs. Regarding neurological complication, like pathophysiology, uh, perhaps there are some mechanism, indirect damage to receptors, cytokine-related injuries secondary to chronic or acute and chronic hypoxia, and retrograde travel along the nerve fibers. And of course, major complications are acute cerebral disease, encephalitis and encephalopathy, Guillain-Barré syndrome, uh, let's say that this disease can affect the central nervous system and the peripheral nervous system. As everybody know, neurologic complications are a cause of poor prognosis. Serious neurological complications are stroke, encephalitis, and Guillain-Barré injury. The incidence reported in this very interesting article published in American Journal of Emergency Medicine entitled Neurologic Complications of COVID-19. So the incidence varies from 6 to 36%, and most often are acute neurovascular complications. And of course, stroke, it was recently reported in Wuhan, Italy, or Holland studies associated with an incidence that varies from 2.7 till 5%. Of course, there are some mechanisms that I just explained in two slides before, like direct damage, mediated cytokine damage that induce cerebral vasodilation, hypoxia, hypercoagulability state, connections with the virus with ACE2 receptors, and of course, the treatment can include thrombolysis and neurovascular procedures, thrombectomy if stroke is verified. But this depends on institutes protocols. Cardiovascular complications are also a very prominent one, and we have to say that 20% may have direct myocardial damage. Myocarditis incidence varies on, let's say, approximately 10%, and 30% of them progress on cardiogenic shock. 18 of the patients suffered from the consequences of pro-inflammatory and procoagulant state. Uh, Symptoms are the same for cardiovascular complications like chest pain, EKG testing abnormalities, irregular heartbeat or arrhythmia, high levels of troponin or other cardiac markers, and of course, complications that are, let's say, described in literature are based on inflammation of cardiac muscle, decreased blood flow in coronary arteries, blood clots as well, and heart failure till cardiogenic shock. Of course, when the pump cannot pump enough, when the heart cannot pump enough blood to vital organs. The mechanism of cardiovascular complications are previous hypertension and vasoconstriction, cytokine-mediated vasodilatation, cardiomyocyte apoptosis, direct damage from procoagulant pro-inflammatory state, let's say the connection of the virus of ACE2 in receptors, a right side failure from pulmonary hypertension and mechanical ventilation, and cardiotoxicity mediated by drugs like plaquenil, azithromycin, or antivirals. In this very interesting article published in 2021, a very recently one, cardiac injury in COVID-19, COVID-19 in intensive care, so published in intensive care medicine. We have some clinical presentations, as you see in the slide, that are demonstrated by abnormalities in biomarkers, by coronary syndromes, chest pain, shock, cardiac arrest, AKG. Abnormalities, troponin elevated, arrhythmia, thromboembolism, of course, and myocarditis, probably faced like a heart failure, and including pathogenic mechanisms, myocardial imbalance, oxygen supply demand. So the supply does not reach the demand of the heart. For example, severe hypoxemia, hypoperfusion, shock, stress-induced cardiomyopathy. Of course, a right ventricular dysfunction, especially in the patients that are intubated and ventilated and mechanically ventilated. Of course, acute respiratory distress, positive pulmonary mechanical ventilation, and let's say pulmonary thromboembolism. Direct viral lesion of endothelial cells and of myocardial cells are two damages that are not to be tolerated because they are, of course, very often in this case. Regarding coagulopathies after COVID-19, the incidence is 20 to 50, mainly thrombophilia attendance, rare bleeding phenomena, and disseminated intravascular coagulation is faced. And we can measure the dimer PT in an air thrombocytopenia. We can find in most cases, especially in sepsis, and alteration of fibrinogen. But we have no, the tendency is to be a prothrombotic situation, but we have also hemorrhagic events. And this article that is published in International Journal of Hematology 2020 with the title COVID-19 associated coagulopathy and disseminated intravascular coagulation explain us all the things that can happen not only for the thrombotic events, but of course for hemorrhagic events. Let's see why hemorrhagic events. For example, from central catheters, hemothorax is verified in some cases, mesenteric hematoma, intracranial bleeding, gastrointestinal, and so far. But of course, thrombotic events are major complications in this let's say uh, disease, as pulmonary embolism or ischemic stroke or acute coronary syndrome. So we can face both the sides of the medal: thrombotic events that are more often, and hemorrhagic events that are likely rare. But in we cannot predict if the patient is a patient is prone to be thrombophilic or to be hemorrhagic. The mechanisms of COVID-induced coagulopathy include prothrombotic and pro-inflammatory state, mediated endothelium damage from AC2 receptors, immobilization, thrombocytopenia from anticoagulants and sepsis, dysfunction of von Willebrand factor, hypoxia, mechanical ventilation, and increased venous filling pressure, central catheter-related thrombotic complications, as you can see all the mechanism here in slide. Uh, the one of the mainstay that it's not yet debatable, it's not yet on debate, is anticoagulants in this disease. So if antiviral therapy in early stage can be used, in advanced stage, no. For example, anticytokines therapy, no in the early stage, but in advanced stage can be used, or the tendency of the other protocols or the other clinics and institutes is to use anticytokine therapy. Antithrombotic therapy is a constant, is a mainstay of the therapy or treatment of this patient. And this is yet, uh, let's say, mentioned or focused on the article in International Journal of Hematology 2020. So antithrombotic therapy is a mainstay of the treatment of this patient until a bleeding episode is verified. Regarding renal complications after COVID-19, in this very interesting article published in 2020, please, in Annals of Medicine with the title Renal Complications COVID-19, a systematic review and meta-analysis, acute kidney injury incidence is reported from 11 to 14% after COVID-19. Renal replacement therapy is needed in only approximately 30% of the patient due to severe electrolyte disturbance or acid-base disorders or and sepsis as well. Mechanisms, of course, are probably the same with acute kidney injury in other situations, but the direct injury mediated by ACE2 receptors, hypoxia, increased venous pressure or and intra-abdominal pressure by prone position, and of course our tendency to maintain dry the patient in order to increase the oxygenation. Risk factors for acute kidney injury are reported as demographic risk factor for acute kidney injury at admission, and risk factor for acute kidney injury during hospitalization, like for example, excuse me, nephrotoxins or vasopressors or mechanical ventilation and high positive and expiratory pressure, and both the situations, fluid overload or hypovolemia. So probably the physician can avoid both the situation that are fluid overload and hypovolemia. Risk factors of AKE at admission can include severity of COVID-19, degree of viremia, respiratory status, of course, leukocytosis, lymphopenia, elevated markers of inflammation, hypovolemia, dehydration, and their abdominalysis. But there are some demographic risk factors that probably some of them are not modifiable. For example, older age, diabetes mellitus, pre-existing hypertension, cardiovascular involvement or heart failure, obesity, chronic renal disease, and some genetic risk factors. Regarding physiopathology of acute kidney injury during COVID-19, we have some mechanisms, direct viral effect and indirect effect. Direct viral effect are collapse of glomerulopathy, endothelial damage, coagulopathy, complement activation, let's say pro-inflammatory state. But of course, in the ICU, we can see some problems with fluid management, mechanical ventilation effects on kidney, nephrotoxins. So a part of our drugs that we use are nephrotoxin, and of course in the development of sepsis and diarrhea. That can induce hypovolemia and acute tubular injury. In the consensus statement, COVID-19 associated acute kidney injury consensus report on 25th Acute Disease Quality Initiative work group, there are the same potential management strategies as in the other disease and in acute kidney injury for COVID-19. And for example, regarding hemodynamic optimization, recommended individualized fluid and hemodynamic management based on dynamic assessment and of the cardiovascular status. So we have to be bedside to the patient and to carefully evaluate his volemia status, his hydric balance, in order to maintain not such a negative. The tendency is to increase oxygenation, but not to go further than that in order to damage the kidney function. Regarding fluid management, for example, the consensus recommend that using balanced crystalloid as essential management for expansion of intravascular volume in patient at risk for COVID-19. This consensus paper recommend to be carefully used with contrast media, and before we can do contrast media for an examination that needs that kind of drugs, we can optimize the volume status. We can avoid nephrotoxin management, nephrotoxins drug, I think, and there are pretty the same like the other consensus for acute kidney injury in other disease. Regarding renal replacement therapy, the modality is that is preferred instead of, let's say, pulmonary edema that we can use conventional hemodialysis. Hemodialysis we can use in other cases continuous renal replacement therapy, especially in the patient with septic shock, and the flow rate that is delivered is recommended 20 25 ml per kilo in hour. So so continuous renal replacement therapy is not so aggressive, can be used very well in septic patient, and has no or little consequences on hemodynamic status of the patient. Septic complications are a major concern in ICU after COVID-19, and 5% of the patients develop multiple uh, organ dysfunction syndrome, with a mortality that varies from 8 to 38% in different states. COVID-19 patients face several important host response dysfunction, as everybody knows, and cytokine coagulation, pro-inflammatory state are very often in this disease. Of course, the lungs are the focus. This is an article published in Critical Care Medicine 2020 that is entitled Sepsis and Coronavirus Disease 2019 Common Features and Anti-Inflammatory Therapeutic Approaches by a group of well-known authors. In Surviving Sepsis Campaign in 2019, that is published in 2020, the first recommendation is that for adults with COVID-19 and shock, it is suggested using epinephrine, norepinephrine, as a first line vasoactive agent. If not available, we can use, or it's not enough, we can use vasopressin or epinephrine. And for adults with COVID-19 and shock, it's recommendation 3 of sepsis survival campaign of 2019 is against using, let's say, dopamine. Of course, the recommendations of 2019 are going on. And for adults of COVID-19 and shock, is suggested adding vasopressin if MAP is not reached by norepinephrine. The target may be MAP of 16 to 65 ml of mercury. And of course, in shock with evidence of cardiac dysfunction and persistent hypoperfusion, despite fluid resuscitation and norepinephrine, it may be logical to add Dobutrex. But of course, we can add corticosteroid regimen, for example, hydrocortisone 2 milligrams per day, to 200 milligrams per day. If all this vasopressin fails to maintain a blood pressure, mean blood pressure, mean arterial pressure from 16 to 60 to 65. But in the Surviving Sepsis Campaign International Guidelines for Management of Sepsis and Septic Shock in 2021, recommendation 3 is that for adults suspected for having sepsis, we suggest measuring blood lactate. Recommend a blood pressure, let's say 65 or higher, not 60 to 65 as the previous guidelines. And the patient in septic shock or sepsis must be admitted to ICU in 6 hours. These are the news, let's say. But sepsis and septic shock and emergency, we recommend that the resuscitation begin immediately with 30 milliliters of kilogram weight of intravenous crystalline fluid. And of course, the recommendations suggest using dynamic measures to guide fluid resuscitation over physical examination and statics parameter alone. These guidelines recommend guiding resuscitation to decrease serum lactate in patient and elevated lactate levels over not using serum lactate. For adults with septic shock, the recommendation suggests using capillary refill time to guide resuscitation as an adjunction to other measures of perfusion. So, one of the most interesting thing that is published concept that is published in Surviving Sepsis Campaign International Guidelines for Management of Sepsis and Septic Shock in 2021, recently published in Intensive Care Medicine 2021, is that for adults with sepsis-induced hypoxemic respiratory failure, we suggest to use high-flow nasal oxygen over non-invasive ventilation. So this is a very important concept, because the other concept about tidal volume, higher pressure or higher the limit of pressure plateau, and so far with PEP use and so far are the same like for acute respiratory distress but syndrome. But for adults with sepsis-induced hypoxic respiratory failure, the recommendation suggests that the use of high-flow nasal cannula oxygen is better than non-invasive ventilation. So regarding antibiotics, this is new here that we suggest against using procalcitonin plus clinical evaluation to decide when to start. So this is not more important or so much important procalcitonin level. If we feel that the patient is going in septic shock, we have to use all the measures that we have. So not wait for let's say for procalcitonin. And for possible septic shock, a high likelihood for sepsis, we recommend, so the recommendation are administering antimicrobials 1 hour of recognition, rapid assessment of likelihood of infection, and of course suggest a time limited course of rapid investigation, and if concerns for infection persist, the administration antimicrobials with 3 hours from the sepsis. But please take in mind that using or waiting for procalcitonin levels, probably we have lose time, and we initiate the treatment no as fast as is required in septic shock. And this is a very demonstrative slide that is extrapolated for Surviving Sepsis Campaign International Guidelines for Management of Sepsis and Septic Shock 2021. That is, shock is present, shock is absent, sepsis is definite or probable, sepsis is possible. So you can see how to administer and how to immediately, either with 1 hour of recognition, we can use antibiotics. So I really thank you and hope that in all the in other situation we have to see each other by face, and to continue the administration, the collaboration face to face or impersonally in among our countries. So thank you, and have a nice day to everybody in the conference, in the Congress. Thank you very much.